What's up, ladies and gentlemen? Welcome back to NeuroSketch with Dr. Kenny. But if this is the first time you've seen this channel, don't forget to subscribe. Welcome to the Basal Ganglia series, and today we're going to talk about the clinical neuroanatomy of the basal ganglia. But this is what we have discussed already, and the job today is to do the Nigrostriatal pathway, but also to discuss the clinical correlates of Parkinson's disease, Huntington disease, and the Hemiballismus. We'll have some few questions here. Have you ever wondered why antipsychotics cause Parkinsonism? You know, antipsychotics, these are the medications that are used to treat psychosis. And the psychosis is when a person runs mad. Yeah, but when these medications are used, they can cause Parkinsonism, and today we're going to figure out how. But the brain works as a motor vehicle system where you have accelerator and you have brake, but sometimes the brake and accelerator can get confused, and you know what happens. Today we're going to figure out what happens when you have that kind of scenario. Can the personality and the mood really change because of movement disorder? Wow, we're going to figure out together today. And lastly, we're going to see how can understanding of these tiny nuclei will help us to treat these movement disorders and memory problems. Okay, quick recap on what we discussed at the time. We said we have the direct pathway and the indirect pathway. The direct pathway is promoting movement, whereby the indirect pathway is inhibiting movement. So the direct pathway is acting as an accelerator of the car system, and the indirect pathway is acting as a brake of the motor vehicle system. And the indirect pathway inhibits unwanted, unnecessary, and the competing movement. What does that mean? That means if you mess up with the indirect pathway, you might witness unwanted, unnecessary, and the competing movement. And if you also disturb the direct pathway, you might be, because the direct pathway is dealing with promoting movement. So if you disturb it, you might see lack of movement or low kind of movement, blood kinesia, slow kind of a movement. And this is what we are going to discuss today. But before we continue, let's figure out the role of dopamine and acetylcholine in basal ganglia and the movement in general. Okay, so the dopamine is promoting movement in both direct and the indirect pathway. This is very important and worth noting. Like, the presence of dopamine will result into promotion of movement in both direct pathway and the indirect pathway. Dopamine has got different receptors, but the most important receptors in the basal ganglia system are D1 receptor and D2 receptor. The D1 receptor is an excitatory in nature. Like, when the dopamine binds to this D1 receptor, it will result into excitation of that neurons, or excitatory neurotransmission. But the D2 receptor is inhibitory in nature. That means if dopamine binds to D2 receptor, it will result into inhibitory neurotransmission, or it will inhibit that neuron from firing. Okay, and the D1 receptors are present in the striatum, but in the direct pathway. They are present in the direct pathway, whereas the D2 receptors, they are present in the striatum, but in the indirect pathway. What does that mean? That means if dopamines bind to the one receptor in the direct pathway, it will result into excitation of this neuron within the striatum. But when the dopamine binds to the two receptors, it will inhibit this neuron within the striatum. And let's go to figure out what happens if that happens. So let's see the effects of dopamine binding into the one receptor. So when it binds here, we go back to our formula. We have positive, negative, negative. So what is the final output? The final output will be high, so there will be promotion of movement in the direct pathway. And then let's see what happens in the indirect pathway. In the indirect pathway, neurons in the striatum, they express D2 receptors. And remember, the D2 receptor is inhibitory in nature. What does that mean? It means if dopamine binds to the D2 receptor, it will result into inhibition of the striatum, of these neurons within the striatum. And if you put it in our mathematics, it's like we have introduced another negative. So we have a negative, 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 positive, negative. Negative, 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 positive, negative, and the outcome will be positive. This is to say dopamine promotes movement in both direct and the indirect pathway. But in other words, it can mean that dopamine inhibits the indirect pathway. It inhibits the indirect pathway in a sense that the purpose of the indirect pathway was to inhibit movement, but at this point we see with the presence of dopamine, the indirect pathway promotes movement. So it's like it has inhibited indirect pathway, and by doing so it has disinhibited a movement. The movement is promoted in both direct and the indirect pathway. In other words, in the indirect pathway, the dopamine has disinhibited the movement, or it has inhibited indirect pathway, and by doing so the movement is promoted. Someone is asking himself, the purpose of indirect pathway is to inhibit unwanted movement. So does that mean that dopamine promotes unwanted movement? No, does not do that, because it is selective. It only it only selects some forms of movement to be executed, and it prevents the other ways round. And now the acetylcholine, we've already seen the role of dopamine in the movement. Now it's time for acetylcholine. But I tell you something very easy to remember, that acetylcholine does exactly the opposite of what the dopamine has been doing. The dopamine was promoting movement in both direct and the indirect pathway, but the acetylcholine will prevent movement in both direct and indirect pathway. Remember, acetylcholine is also an excitatory neurotransmitter, but it has got a number of receptors. Types of receptors of acetylcholine, you have muscarinic receptors and nicotinic receptors. We're not going to discuss about those today, because I told you we have a separate discussion talking about these neurotransmitters. But muscarinic receptors and the nicotinic receptors, today we're dealing with the muscarinic receptors, and they are represented by M. So we have M1 through M5, and of significance in our discussion today is M1 and M4 receptors. M1 receptors and M4 receptors. Now, those neurons that are expressing the D1 receptors within the striatum, they also express M4 receptors in terms of acetylcholine. Remember, D1 was for dopamine, but M4 is for acetylcholine. Same applies here. D2 was for dopamine, but M1 is for acetylcholine. Something easy to remember as well, M4 is inhibitory in nature. So when acetylcholine binds to M4 receptor, it will result into inhibition neurotransmission, or inhibitory neurotransmission, or inhibition of that neuron. And when acetylcholine binds to M1 receptor, it will result into promotion, it result into excitatory neurotransmission, because M1 receptor is an excitatory neuron. So let's see what happens in terms of mathematics as well. So we have in the direct pathway, we have negative, negative, and negative. We have a total of 3 negatives. See, 1, 2, 3. So the final output is inhibitory neurotransmission, which is negative, inhibitory neurotransmission. Let's see what happens also in the indirect pathway. And the indirect pathway, when acetylcholine binds, it excites. So it's an excitatory. Remember, in M1 is excitatory. But when you put into our final mathematical equation, you see that you have negative, you have a positive, negative, negative, positive, negative. In the end, we have like 3 negatives, and the output will be low. What does that mean? That means acetylcholine, whether it binds to direct or indirect pathway, it will result into inhibition of inhibitory neurotransmission. So it will result into inhibition of movement, so it prevents movement in both direct and indirect pathway. But there should always be a balance between the two neurotransmitters, and whenever you have disturbance of either of them, the other one will peak. For example, if you have disturbance with dopamine, that means the acetylcholine will peak. And remember, the effect of acetylcholine is to prevent movement, and this is what will be observed to a patient. The other way is true, that if you have disruption of acetylcholine, dopamine will peak, and the result will be promotion of movement in both limbs. This is not what we want. Okay, we want a balance between the two systems. Okay, so we have a summary of these two neurotransmitters, dopamine and acetylcholine. And remember, the overall effect of dopamine is to promote movement, and the overall effect of acetylcholine is to inhibit movement. How does it inhibit? By inhibiting the one receptor and promoting the two receptors. But this is exactly the opposite of what's happening in the pathways using dopamine as neurotransmitter, because it promotes the one and inhibits the two receptors. Let's go to the Nigrostriatal pathway. So the Nigrostriatal pathway, that means is the pathway between the nigra, which is the Substantia nigra, and the striatum. This is striatum, which means caudate, nucleus, and the putamen. So this is like a system of checks and a balance. This is a way that the striatum is modulating the effect of the substantia nigra in releasing dopamine, and also how the substantia nigra is modulating the effect of the striatum in releasing acetylcholine. So it's a system of like checks and a balance. And this is what happens. The substantia nigra pars compacta releases dopamine, and the dopamine is acting on the 1 and the 2 receptors in the medial spine fibers, medium spine neurons, and this will result into inhibition of acetylcholine release. Dopamine from substantia nigra inhibits this one from producing acetylcholine, from releasing acetylcholine. But exactly the opposite is happening within the striatum, because from the striatum we have the acetylcholine, which is acting at the MSN neurons and the dopaminergic terminals to decrease, to modulate the effect of the release of dopamine in these terminals. And this system should also be in balance. And whenever you have the disruption of one, the other one can pick up, and you end up with movement disorders. Okay, now we're going to the hypokinetic and hyperkinetic movements. But too much dopamine means you're promoting movement too much, so you'll be like dancing. And if you have too little dopamine, means you are frozen. Why? Because the acetylcholine picks up, and then you have what? You have inhibition of movement in both direct and the indirect pathway. Okay, so too much, this is just a repetition. Too much dopamine will result into hyperkinesia. Hyperkinesia. Movement will be too much. And if you have too little movement, too little dopamine, means you have hypokinesia, like in Parkinson's disease. But hyperkinesia is like in Huntington disease. Let's start with the Parkinson's disease. This disease was named after James Parkinson in the year 1817, and it represents hypokinetic disorders. In hypokinetic disorders means the movement is reduced. And if the movement is reduced, what do you think? Do you have too much dopamine or too little dopamine? Yes, too little dopamine. That's why we are like frozen. So this is kind of a frozen kind of a disease. The cause of this disease is not known, but it's thought to be neurodegeneration. That means we have loss of certain neurons within the brain, and specifically the neurons that are producing dopamine. Remember, dopamine is coming from the substantia nigra pars compacta. So the neurons within the substantia nigra pars compacta, they are degenerating. They are removed slowly from the system, and this disease is a progressive disease. That means the situation today will be worse in 2-3 years to come. For example, if I have 1 billion neurons today, after 2 years maybe I will have 500 million, and after 2 more years I will have maybe 200 millions, and the process is going on. We have progressive loss of these neurons that are producing dopamine, and this is why this disease is referred as a neurodegenerative disease, progressive neurodegenerative disease. Globally, it affects 129 people out of 100,000 people. So as we've said, the cause is not known, but we have some identifiable risk factors that might predispose you to get Parkinson's disease. But this doesn't mean when you meet these factors you will develop Parkinson's disease. No, these are just risk factors. They predict you having developing Parkinson's disease in the future. So number one is age. Age is the most determinant factor of the Parkinson's disease, and ideally people above 65 years of age are more likely to develop Parkinson's disease than the younger population. But that does not mean that people below 65 years cannot develop Parkinson's. And by the way, study shows that about 25% of people with Parkinson's disease, they are aged below 65. Yeah, maybe they are like the age of you and I. And I've seen this circulating video in the internet. Actually was posted by BBC in the Instagram, showing this lady. I believe she's Kenyan, and looking at her, you can't say that she's 50s or maybe late 40s. No, I think she's late 30s or early 40s. Let's watch her a bit.
Asubuhi nikiamka na mkanga nikianza kutetemeka. So nimeza tembea kwanza, ningoje ifanye kazi, niende nifanye tizi, niende nitafute breakfast, nioge, whatever ile kitu nafaa kufanya. But ile kitu na rule maisha yangu kwa sasa ni dawa.
Ni dhana potofu za aina gani ambazo umekumbana nazo?
Ya kwanza ni mimi ni mlevi, nimekunywa pombe nafaa kutoa.
That's how Parkinson's looks like. That's how Parkinson's disease looks like. And as we've said, even though age is the most determinant factor, it affects more old population, but it can happen into young population. And the thing is, we have progressive loss of neurons that are producing dopamine. What are the other risk factors? Men are more likely to be affected by Parkinson's disease than female by that ratio. But if you have first degree relative, you are at 2 to 3 times higher risk of getting Parkinson's disease than the other population, than the general population. So let's say if you have your father or your mother or your sister with Parkinson's disease, you are at 2 to 3 times higher risk of getting Parkinson's disease than an average person. But you can also have some environmental predisposition, like pesticides, pollutions, nitric oxide, hydrocarbons, copper, manganese and lead. They can predispose you to get Parkinson's disease. But if you also have comorbidities, obesity, too much weight, diabetes, traumatic brain injury, constipation, they can all predispose you to get Parkinson's disease. Something very strange here is that smoking is protective. If you smoke, you are at low risk of developing Parkinson's disease. That means you are in advantageous side if you smoke. But smoking will protect you against Parkinson's disease, but it will predispose you to lung cancer, among other diseases. So smoking is not good. Caffeine will protect you from Parkinson's disease. Exercise, of course, the use of ibuprofen and the statins will all protect you from getting Parkinson's disease. We have already seen that lady, and let's go to the mechanism of Parkinson's disease. So we have said the main mechanism of getting Parkinson's disease is having loss of neurons that are producing dopamine. And these neurons are found within the Substantia nigra pars compacta. These neurons, they degenerate. And once they degenerate, they result into low amount of dopamine. Low amount of dopamine means we are disturbing our equilibrium, and acetylcholine goes higher. And if the acetylcholine goes higher, you remember it will prevent movement in both direct and the indirect pathway, and this is what accounts to a lot of symptoms in Parkinson's disease. But we do also have involuntary skeletal muscle contractions that will result into tremor. You have seen that lady with this amount of tremor. You see that tremor is accounted by involuntary muscular contraction. But there is something I think you need to hear. The amount of the striatal dopamine loss seems to be more than 80%. What does that mean? That means in the striatum, they are experiencing loss of more than 80% of dopamine that used to come. For example, I used to receive 100 dopamine units, but right now I'm receiving only 20. So I have more than 80% loss of dopamine that I'm receiving right now compared to the previous distribution. But in the Substantia nigra pars compacta, the amount of loss of neurons is seen to be only 50 to 60%. But deficit, which is seen in the striatum, is more than 80%. What does that mean? That means we have too much loss of dopamine than the actual loss of neurons. The actual loss of neurons in the pars compacta is 50 to 60%. But the loss that is experienced in the striatum, the receiver, seem to be more than 80%. And we have some theories that are explaining about this, accounting this. Number one is electrograde degeneration, and number two is multiple projection. Like one neuron would probably project into more than one neurons in the striatum. So one neuron in the pars compacta projecting to more than one neuron in the striatum. That means if we damage this neuron, we experience much loss in the receiver, which is the striatum. And what are the compensatory mechanisms once having a low amount of dopamine? Number one, we are increasing dopamine. Remember, what is happening in the Parkinson's disease is we have progressive loss of neurons that will produce dopamine. Yeah, and the remaining neurons now will strive to produce dopamine so as to compensate for the loss that is seen in the striatum. Yeah, so the remaining neurons will increase production of dopamine so as to fulfill, at least to close this gap which is seen in the striatum. But another mechanism is to delay the uptake, to decrease the uptake of dopamine. Remember, the principle of transmission in the synapse is that you have presynaptic, postsynaptic, and this presynaptic releasing the neurotransmitter to the gap, and this neurotransmitter is acting to the postsynaptic neuron, and then after a certain time, this neurotransmitter will be reabsorbed back, will be taken back to be stored in the presynaptic neuron to wait for next action potential. So what is happening in the compensatory mechanism of Parkinson's disease? There is delaying of the uptake in this neurotransmitter back to the presynaptic neuron so that it can act and compensate for the loss of dopamine. Remember, we have loss of dopamine that would be produced by other neurons. Now, by extending the stay of this neurotransmitter in the junction here, it would at least compensate for the loss of dopamine that was seen, and that's another mechanism of compensation. In short, that's what's happening in the direct and the indirect pathway, and the effect is we have decreased the movement, and this is what accounts to a lot of symptoms in Parkinson's disease. These are the symptoms in Parkinson's disease. Number one, we have tremors, and tremors are due to involuntary muscular contraction, but you have muscular rigidity, we have bradykinesia, and the bradykinesia is composed of three things. Number one is slowness of movement, slowness, like you are thinking but you're acting slowly. Another component of bradykinesia is hypokinesia. The hypokinesia means you have low amplitude of a movement you are doing. But number three is a sequence of effect. That means there is always decreasing. If you are repeating a movement, there is always decreasing in the amplitude of this movement. We're going to see how. Let me show you how this. You see, so that's the sequence of effect, the sequence effect, that as long as the movement is continued, there is decrease in amplitude. This is why you see like is kind of whatever. I don't know how to explain that in English. Okay, but we have postural and gait abnormalities. You see how the posture of this guy is, and the gait. You have they have also mask-like appearance on their face. They have decreased the range of movement, and the words written smaller when they are writing because of reduced range of movement of different joints. The words are usually written smaller than how this person used to write. There is always difficulty in starting, adjusting, or stop a movement. Again, you can see this guy. So it's difficult for him to stop this movement, and this is one among the symptoms of Parkinson's disease. Speech might also be affected. Now you see activities like shaving, cutting foods, and buttoning the shirt take longer, because we've seen that Kenyan lady on the BBC how the tremors are. So you can imagine if you want to button your shirt, it's hard because of that tremor. So these are the typical symptoms of Parkinson's disease, classic symptoms of Parkinson's disease. Number one is the tremor, number two is rigidity, number three is akinesia, that represent bradykinesia, and posture and balance. And I've written this to get a mnemonic, which is a trap: tremor, rigidity, akinesia, and posture. You can always remember. So what is the treatment of Parkinson's disease? The idea, remember, always remember, the problem with the Parkinson's disease is that you have loss of neurons that are producing dopamine. So we have loss of neurons, and we cannot replace that. When you have loss of a neuron, you cannot retrieve it back. You cannot treat this person to regain back the neuron which is lost, because it's kind of gone. It's dead already. Okay, so what we can do is to give something to increase amount of dopamine in the body, or to reduce acetylcholine, because if you have too little dopamine, the acetylcholine picks up, and then it will result into inhibition of movement in both direct and indirect pathway. So these are the goals of the treatment. The medication cannot change the progression of the disease and cannot cure the disease. They can only, treat the symptoms. And what are the symptoms? These are the symptoms that we have seen. So number one, the goal is to increase the amount of dopamine or to reduce acetylcholine. Yeah, because you see already the dopamine is low, acetylcholine is high, so the treatment is to increase dopamine or to reduce acetylcholine. Okay, what are the options that we have in treatment of Parkinson's disease? Number one, we have medications that are increasing the amount of dopamine. For example, levodopa is increasing amount of dopamine. We have medications that are decreasing the uptake of dopamine. We have already seen that one among the compensatory mechanism of the body is to decrease the uptake of dopamine. So you can give a medication that is helping to decrease the uptake of dopamine back to the presynaptic neuron. But you can also have medication that are decreasing the metabolism, the breakdown of dopamine, so that you have too much dopamine. Remember, the problem is where we don't have neurons, and so dopamine goes down. So if you break down dopamine, means the problem is going bigger, correct? So if you have medication that are decreasing the metabolism of dopamine, they will result into availability of dopamine. But if we don't have this, we can also use the medication that are decreasing the amount of acetylcholine. Because the problem here is that you have, if dopamine goes down, then acetylcholine becomes too much, and then the movement will be inhibited. So you want to decrease the amount of acetylcholine. That's why you can use medications like benzotropine. So if all these medications have failed, you have another alternative, the last resort, which is called deep brain stimulation. This is the last resort in treatment of Parkinson's disease. There are a lot of theories, hypotheses about this deep brain stimulation. DBS is also written as DBS, and the idea is this deep brain stimulation inhibits the subthalamic nucleus. Remember, the subthalamic nucleus is present in the direct pathway, and the function of the subthalamic nucleus was to increase inhibition of thalamus by promoting the globus pallidus internal segment. Remember that the globus pallidus internal segment was inhibiting thalamus, and it was receiving help from the subthalamic nucleus. Now, by blocking the subthalamic nucleus means the thalamus is less inhibited. Yeah, but this mechanism can also happen at the internal segment of globus pallidus, so that the thalamus is disinhibited, like the thalamus is not inhibited, and so we have promotion of movement in both. Like the thalamus is not inhibited, and so we have promotion of movement in this indirect pathway, and so we have mitigated our problem, which is Parkinson's disease. But remember, this does not cure the problem, but only it mitigates the symptoms. So we have another important terminology, which is called Parkinsonism, and the Parkinsonism is not the same as Parkinson's disease. These are two different terminologies and should never be confused. Ideally, Parkinsonism means a person is presenting as a patient with Parkinson's disease. For example, me, I do not have Parkinson's disease, but I present as a patient with Parkinson's disease. How? By having tremors, rigidity, and bradykinesia. These are the features that we expect to find to patient with Parkinson's disease. But I don't have Parkinson's disease and I present with this feature. So that is called Parkinsonism. So Parkinsonism is like a bigger umbrella that is covering a lot of different diseases that can present as the patient with Parkinson's disease. This is a broad terminology, and it represents various neurodegenerative disease. They have similar presentation. This is to say, not every patient with Parkinson's with Parkinsonism will have Parkinson's disease. Yeah, I present with these features. That doesn't mean that I have Parkinson's disease. Remember, the Parkinson's disease is a neurodegenerative disorder. For you to be able to have Parkinson's disease, they should confirm that you have degeneration of neurons within the substantia nigra pars compacta. Otherwise, you are just having Parkinsonism. Okay, and studies show that 80% of people with Parkinsonism, they have Parkinson's disease. That means we have 20% of people that they have Parkinsonism, but they do not have Parkinson's disease. They have these symptoms and features that are resembling Parkinson's disease, but they do not have Parkinson's disease. These features were attributable by something else. Yeah, they were caused by something else. So the attempt should always be to rule out other possibilities of Parkinsonism before you label a patient as having Parkinson's disease. What are the other possibilities? We have medication-induced Parkinsonism. Medications like haloperidol, which is falling under typical antipsychotics, they can result into Parkinsonism. Yeah, Parkinsonism, and these symptoms are called these are one of the extrapyramidal symptoms. They have this because haloperidol and this typical antipsychotic, they work by blocking dopamine receptors. And remember, we have seen the dopamine receptor. If you block the dopamine receptor, means the dopamine will not be able to act. And if you don't have action of dopamine, means the movement will be reduced in both direct and indirect pathway. Because the dopamine was acting in both direct and the indirect pathway to promote movement. Now you have blocked the receptors of dopamine, so you do not have this movement. And this is why patient taking antipsychotic, remember the first phrase in our question, the patients taking antipsychotic, they might present with Parkinsonism, features of Parkinson's disease. And let me mention something. Parkinsonism that is not due to Parkinson's disease is labeled as secondary Parkinsonism. The primary Parkinsonism is caused by Parkinson's disease, but the secondary Parkinsonism is not caused by Parkinson's disease. So, for example, the medication-induced Parkinsonism is also referred as the secondary Parkinsonism. And secondary Parkinsonism, they do not respond to dopamine therapy, because the problem here is not dopamine. The problem here is something else. For example, we have blocked the receptors of dopamine, so we do not have deficiency of dopamine, but we have something else. And secondary Parkinsonism does not respond to dopamine therapy. Secondary Parkinsonism does not respond to dopamine therapy, because the problem here is not dopamine. We have dopamine, you have neurons that are secreting dopamine, but the problem is something else. For example, in this condition we have seen, we have blocked the dopamine receptors, so no matter how much dopamine we give, the symptoms will still be there. So the diagnosis of Parkinson's disease by ruling out other possibilities like medications and some other forms. Okay, let's talk about another movement disorder, which is called Huntington disease. And Huntington disease represents hyperkinetic movement disorders. Parkinson's disease was representing hypokinetic movement disorders, but Huntington disease is representing hyperkinetic movement disorders. So this is a genetic condition. That means you can inherit from your parents. And the problem here is that you have degenerations of neurons in the striatum. The neurons that are releasing acetylcholine and the GABA, they degenerate. So in the end, that you do not have enough acetylcholine and enough GABA for neurotransmission. So let's see what happens in the indirect pathway. We have removed this one, and when you put mathematics, you will see that you have negative and positive. So you're promoting movement in the indirect pathway, and this is what defines the hyperkinetic nature of Huntington disease. The key sign in Huntington disease is chorea, and chorea is like dance. It translates to dance. So the patient is having like dancing movement. Whenever he or she walks, he is like dancing, and this is called choreiform movement. But Huntington disease is also associated with psychiatric problems, and this is because there is a complex interaction in the striatum, but neurons in the striatum, they also control behavior and memories. So if you have damage of these neurons, that means you end up with psychiatric mental problems, behavior problems, mental problems, and it might not necessarily be behavior, but mental problems and the dementia. Another important thing to note is that we have said Huntington disease is a genetic disorder. So you might have these genes earlier in life, but the symptoms do not develop until the patient is at least 30 to 40 years of age. So between 30 and 40 years is when the patient will start presenting with symptoms of Huntington disease. What are the symptoms again? The choreiform movement, dancing movement, but they will also have the psychiatric problems and mental issues, mental deterioration. Dementia is loss of memory, so they might also have loss of memory because these neurons are also very important. Neurons within the striatum are also very important in memory processes. And another important thing also to note in the Huntington disease is that in advanced stages of Huntington disease, you might see effect both in direct and indirect pathways. There occur degenerations in both direct and indirect pathway, and so the result is rigid hypokinetic Parkinsonian state. Not Parkinson's disease, Parkinsonian state, because you've affected both pathways. We have said you can also have progressive mental deterioration because of those neurons taking part in behavior and death usually occurs 10 to 20 years after the first symptoms. So let's say this patient presented for the first time at 30 years of age. After 10 to 20 years, that means in 40s and or 50s, this patient might die. And the main causes of death here is the infection such as pneumonia and injuries that are related to fall, because this is dancing like movement, so they fall. So Huntington disease shows how important it is to suppress unwanted movement, because this is what happens when the indirect pathway promotes movement. You have this unnecessary movement, and this is how the patient is walking like. So it's a dancing like movement, which is called choreiform movement. Let's now go to the treatment of Huntington disease, and this disease has got no cure. All what you're doing is to treat the symptoms. You cannot reverse this condition. You can only treat the symptoms, and treatment is just symptomatic and supportive. Just symptomatic. We cannot cure Huntington disease. And remember, the problem with the Huntington disease is that you have too much dopamine. Why do you have too much dopamine? It's because we have lost the neurons that are producing acetylcholine. Remember, I told you we should have the balance between acetylcholine and the dopamine. So the acetylcholine is gone. That means we have too much dopamine. What do we need to do here is to reduce this amount of dopamine so as to mitigate the symptoms. And one among the medication that we are using is the antipsychotics. Remember, I've just showed you there that antipsychotic, they block dopamine receptors. So by blocking dopamine receptors, they are decreasing the action of dopamine, which is promoting movement, and so we are reducing this movement promotion in both direct and indirect pathway. That is it in Huntington disease. Lastly, let's talk about the Hemiballismus. So Hemiballismus, and ballismus means is explosive throwing movement. Explosive and throwing movement. Let me make it very clear at this point. Hemiballismus is like a severe form of chorea. Chorea is that dancing movement, and hemiballismus is like chorea with high amplitude. So someone is like fringing, this kind of movement. So ballismus or hemiballismus is a sudden, violent, unilateral proximal fringing movement of arms and legs, and usually it's lateral arm and leg, but the damage is happening in the contralateral part of the brain. At which region? At the subthalamic nucleus. Let me show you here. The subthalamic nucleus is what is affected in hemiballismus. So in hemiballismus, the problem is happening at the subthalamic nucleus. And if you have damage to the subthalamic nucleus, it means you are decreasing the ability of this nuclei to inhibit thalamus. In the end, this thalamus is becoming disinhibited, like it promotes movement, because we have removed the subthalamic nucleus, and subthalamic nucleus was helping these two nuclei to inhibit the thalamus. Now removing subthalamic nucleus means the thalamus is disinhibited, so the movement happens. The movement happens. But what are the most common causes of damage to this subthalamic nucleus that can result into hemiballismus? Number one, the common cause is stroke. So a stroke which is involving the subthalamic nucleus can result into hemiballismus. But you can also have another different causes that can affect the subthalamic nucleus, not to mention tumors, brain mass that are compressing this subthalamic nucleus. But we have infections like toxoplasmosis, we have trauma to this lesion, we have TB, and we have some other metabolic disorders that can injure the subthalamic nucleus. And the mechanism, as we've said, injury to subthalamic nucleus will result into disinhibition of the thalamus, and the result is high amplitude movement, which is called hemiballismus, which is actually severe than chorea that we have seen in Huntington disease. What are the treatment options in hemiballismus? Now, compared to Parkinson's disease and Huntington disease, hemiballismus is usually self-limiting. When you resolve a disorder that is causing the injury to the subthalamic nucleus, you might see patient improving. So this one is to treat the underlying cause, and then this problem will resort itself. Now let's see this woman with hemiballismus. I want you to pay much attention, comparing our information here and what's happening to this woman for consolidation. Number one, notice the amplitude of movement. Number two, notice the ipsilaterality. Same side of the arm and leg are affected, the ipsilateral arm and leg, but that means the effect that's happening in the brain is on the contralateral side. Yeah, because we have right arm and right leg affected, that means to the brain the left side is affected, the left subthalamic nucleus. Remember, we have the left and right subthalamic nucleus. And another important thing to notice is the presence of bleeding within the subthalamic, which is the stroke. And I've said the stroke is the most common cause of hemiballismus. Stroke involving the subthalamic nucleus. This is the subthalamic nucleus, and we have stroke there. That means we end up with hemiballismus. Stroke was happening right there. And that's all that I have in hemiballismus. Let me show you a quick recap, a quick brain dump. The main two movement disorders are Parkinson's disease and Huntington disease, and I have included everything that you need to remember. You can take a screenshot of this this picture, and then you can walk along with it. This is what you need to remember in your exams. And I have side-by-side table comparing hemiballismus movement and the chorea movement, but the main difference is the amplitude. The amplitude is high in hemiballismus, but it's little lower in chorea, like dance. And I have included everything that you need to remember. But I have some questions that I need you to attempt them. That's question number 1. This is question number 2, and this is question number 3. And it was nice having this discussion with you. If you've enjoyed this discussion, don't forget to like, comment, and share with your friends. But if this is the first time you're seeing this channel, don't forget to subscribe, and see you really soon. Bye bye.